This is a Zika update for health professionals living in North Queensland. This update has information that is correct as at the 12th of December. Please contact your local public health unit for further information. So Zika virus is a flavivirus that's closely related to other viruses like dengue, yellow fever, Japanese encephalitis and West Nile virus. This is important particularly when it comes to testing and cross-reactivity with serology if people have had a similar flavivirus. The Zika virus itself has a few different strains, African strains and Asian strains. So the history of Zika, and thank you for the CDC for this map. Zika was first discovered in the Zika forest of Uganda in 1947. There have been outbreaks since then in several countries, particularly Southeast Asia. There was an outbreak in Micronesia on Yap Island in 2007, and a lot of the clinical information about outbreaks we have got from Yap Island. There was further outbreak in the Pacific in French Polynesia in 2014, which is where the link between Zika and Guillain-Barré syndrome was discovered. And then, as we know, the outbreak in Brazil that has since spread to other countries within South America and now Florida within the US. Zika is primarily transmitted through the bite of an infected mosquito. So the mosquito, and there's two main mosquitoes here, Aedes aegypti and Aedes albopictus. The mosquito bites someone with Zika virus. Then that mosquito, 8 to 12 days later, becomes infective to other humans. And when it bites other humans, can pass on the Zika virus. That mosquito transmission is the main form of transmission of this virus. Other ways that that Zika virus can be transmitted include from a pregnant lady to her unborn baby. Sexual transmission is also possible, as is blood transfusion. And we'll talk about those modes of transmission. Firstly, let's talk about the mosquitoes. As I said, there's two mosquitoes of interest here, Aedes aegypti and Aedes albopictus. These are the same vectors for dengue. The incubation period within the mosquito for that mosquito to become infective to humans is about 8 to 12 days. And that's very similar to the situation with dengue. So the mosquito on the left, Aedes aegypti, that's found in North Queensland towns, particularly Townsville, Charters Towers, around the Cassowary Coast region of Innisfail, Cairns, Mossman, Port Douglas regions. It's also found on Thursday Island, Boigu Island, Horn Island and the Northern Peninsula area of Cape York. This mosquito loves humans. It's very adapted to human habitats. It bites during the day. It's not one of the pest mozzies that bites at dusk and dawn. This is a day biter. It lives inside the house and it hides in dark places such as under tables, under chairs, around cupboards. Once the mosquito gets Zika virus, it is infective for the rest of its life. Aedes albopictus is a different mosquito. In Australia, Aedes albopictus is present in the outer Torres Strait Islands, except for Saibai. There's a similar mosquito species in Boigu, but it's not Aedes albopictus. This mosquito breeds in a similar fashion to aegypti in small amounts of water around the house. Both natural water deposits, such as in the bases of palm fronds, as well as artificial containers at the base of your pot plants. Aedes albopictus, though, is generally found outside, and it likes to rest on dark, shaded foliage in the yard. What do we know about these mosquitoes and viruses? So the area that the mosquitoes can live is in these tropical areas between the two red lines there. We know that dengue can be transmitted in all of the yellow shaded countries. In Australia, the Aedes aegypti mosquito can live in the light brown shaded sections here. However, in the past 20 to 30 years, outbreaks of dengue have only been in the dark areas, including the Torres Strait. So there are parts of North Queensland where there may be Aedes aegypti mosquitoes, but there has not been transmission of dengue for the past 20 to 30 years. Other modes of transmission, as I said, materno-fetal transmission is the most serious form of transmission, and we'll talk about why that is. There have been no cases of transmission of Zika virus through breastfeeding. Sexual transmission is another mode of transmission, and this can be from male to male, male to female, and female to male. We know that Zika virus PCR, so the DNA of the Zika virus, can be isolated from semen for up to 188 days after symptom onset. It can also be isolated from vaginal swabs for up to 2 weeks after onset. Transmission has been reported from anal sex, oral sex, and vaginal sex. Zika virus can also be transmitted through blood transfusions. Let's talk now about the clinical infection. So after being bitten by a mosquito, it takes between 3 and 12 days for symptoms to appear. Symptoms may only appear, though, in 20 to 50% of people. Up to 4 in 5 cases of Zika virus may go unnoticed by the patient because they have no symptoms. We know from the outbreak on Yap Island that the infection rate can reach up to 70%. The symptoms of Zika virus: the rash is a maculopapular rash that starts on the face, can be itchy, it then spreads down to the trunk and other areas. A mild fever is also common. Small joint arthralgia, particularly of the hands, and red eyes, so non-purulent conjunctivitis, are the 4 most common symptoms. Other symptoms include muscle ache and headache. The illness, if you do get it, is usually mild and lasts up to 1 week. There's no treatment for Zika virus infection, and it's supportive treatment only. It's recommended people use paracetamol and avoid non-steroidal anti-inflammatories, as that may increase the risk of bleeding. Zika virus has come to everyone's attention because of the complication of microcephaly. It's unclear at this stage how common that complication is. We know from French Polynesia and a retrospective study there that 1% of symptomatic women had a baby with microcephaly. We know from Brazil that that figures 29% of symptomatic women who had a baby with microcephaly. Microcephaly, though, is not the only birth defect possible. There have been reports of hearing loss, eye defects, impaired growth, miscarriage, and recently information about microcephaly developing after delivery. Zika virus can cause a problem at any gestation. The other complication of Zika virus worth mentioning is the risk of Guillain-Barré syndrome. This is a rare complication. Other rare complications include meningitis, uveitis, and myelitis. In North Queensland, I'm going to talk about the risk in various locations. Firstly, the risk in Torres Strait. Torres Strait has two vectors, Aedes aegypti on Thursday Island, Horn Island and Boigu Island, and Aedes aegypti is also present in the Northern Peninsula area. The rest of the Torres Strait has Aedes albopictus. Having two vectors means that there is a risk of a Zika outbreak within the Torres Strait. We know that there's Zika in Papua New Guinea, and given the proximity to Papua New Guinea that the Torres Strait has, it's possible for someone to bring Zika into the Torres Strait as an import. We also know that the Torres Strait has had dengue outbreaks before, including one in 2016. Mosquito populations increase with the wet season. So there is a risk with the upcoming wet season. We have not recorded a Zika outbreak in Australia before, and so the population is not immune. The risk in Cape York is possibly less. We know that some communities in Cape York have Aedes aegypti, but we do know that there's been no dengue outbreaks in the last 20 years. Again, we do expect to see an increase of mosquito population with the wet season, and Cape York has a non-immune population. The Cairns and Townsville regions, though, represent a bigger risk than what exists within Cape York. We know that around Cairns, so from Mossman, Port Douglas to the north and down to the Cassowary Coast, Innisfail region in the south, we know that there's Aedes aegypti. In the Townsville region, it's Townsville, around Townsville and west out to Charters Sowers. We know that there is Aedes aegypti. We also know that all of those locations have had previous dengue outbreaks. There has been no Zika virus in Australia from local outbreaks before, and the population is therefore not immune. We do expect to see increase of mosquito numbers with the wet season. The other risk for Cairns and Townsville is that we now have direct flights to Papua New Guinea the Philippines, where there's Zika, Singapore, where there's been a recent Zika outbreak, and Bali. The fortunate thing for these regions is that the Eliminate Dengue program with Wolbachia within the Aedes aegypti mosquitoes will help to prevent outbreaks. That Wolbachia bacteria blocks the virus within the mosquito, so the mosquito cannot then pass it on to other people. In terms of prevention, what can we do to prevent a Zika outbreak? Given that up to 4 out of 5 people may be asymptomatic, we might not be able to prevent an outbreak. We can act on symptomatic cases, and this requires early detection and notification on clinical suspicion. This notification is to your public health unit in your region. As a public health response, we are doing more testing for Zika virus. This includes adding Zika testing on to any dengue virus request. We have also done health promotion and hosted on the PHN website are some of the resources that your patients can access. Both Cairns and Townsville have done a lot of work to control the Aedes aegypti mosquito, particularly at sites where pregnant women may visit, such as antenatal clinics. The other important message to prevent the Zika outbreak is the message around safe sex to prevent sexual transmission. I'll talk a little bit about how to control the actual mosquitoes. Firstly, Aedes aegypti mosquito. As I said, this breeds in those small artificial containers around the house, such as old tyres, bases of pot plants, palm fronds lying on the ground, wading pools for the children, are all potential breeding sites for Aedes aegypti. The message that has been in the community for several years, tip it, store it, throw it, therefore remains important. So tip out the water, check your house once a week, store things under cover where they won't get wet, or throw it away. The other thing that works for this mosquito, Aedes aegypti, is interior residual spray. This can give up to 90% protection from dengue for occupants. On the PHM website, you will see a video of how to spray your house. This is also accessible for your patients to use. IRS spray involves using a long-acting crawling insect or cockroach surface spray that's available from supermarkets and hardware stores, and spraying in those dark hiding places where the mosquito likes to rest. This can be done every 4 to 6 weeks. Another important aspect for your patients is to prevent bites. So ensure that houses have appropriate screens and screens are repaired or replaced. Your patients can do interior residual spray at home themselves and repeat that every 4 to 6 weeks. Repellent may help prevent mosquito bites. and repellents containing DEET and picaridin are safe to use in pregnancy. Read the instructions on these repellents and reapply them as directed on the instructions, remembering that Aedes aegypti is a day-biting mosquito, not a pest mosquito that upsets your barbecue at night. This is a day-biting mosquito that will bite when you are sitting at home. The recommendation for clothing is as with other mosquitoes: light coloured long sleeves, long pants, and something to cover the feet, because this mosquito likes to bite the feet. Aedes albopictus is a different mosquito. This breeds in similar habitats to Aedes aegypti, and so the tip it, store it, throw it message is still relevant. For the Outer Torres Strait, this includes tipping out coconut husks and ensuring that they're thrown away, cleaning up yards, including of old palm fronds. This mosquito does not live in the house as much as Aedes aegypti, so interior residual spray is not recommended. Instead, what works for this mosquito is what's called harbourage spray of vegetation around the house where this mosquito goes to rest. For people living in the Outer Torres Strait, we recommend that they install screens on their houses and they use the same repellents. We know that DEET and picaridin work effectively against this mosquito, and it's safe to use in pregnancy. Similar advice for clothing is recommended. We're enhancing the surveillance for this virus. As I stated before, Zika testing has been added on to dengue testing. The important thing from a health professional perspective is for you to notify public health on clinical suspicion. Be alert for Zika virus infection in people that have travelled to the Pacific Islands, to Papua New Guinea, to South America or to Southeast Asia. We've also developed testing guidelines with recommendations on who to test and when to test. You can advise patients who are planning travel overseas. If your patient is pregnant, we recommend that they do not travel to a country that has Zika virus. It's also worth extending that same advice, do not travel, to a country that has endemic dengue. This is because the same mosquito that transmits dengue transmits Zika virus. If your patient's contemplating pregnancy, we recommend that they do not travel to those countries. The Commonwealth Department of Health, health.gov.au, has a list of countries that have reported Zika virus. If a sexual partner travels and the pregnant partner does not travel, we recommend that the couple use barrier contraception or abstain from sex for the duration of the pregnancy, or if the male travels, we recommend they delay plans for pregnancy for 6 months, after return. If the female partner travels, we recommend delaying pregnancy for 8 weeks after returning from a Zika-affected country. Whilst travelling, your patients should be using mosquito repellent. Consider the use of a bed net during the day, using permethrin-treated clothing, and they may even consider using interior residual spray within their accommodation when travelling overseas. We do not have Zika virus in North Queensland currently. The disproportionate burden of Zika virus falls to pregnant women. So the advice currently to prevent Zika virus and a Zika outbreak is for pregnant women particularly to use interior residual spray at home every 4 to 6 weeks. Avoid being bitten by mosquitoes. Tip it, store it, throw it, and ensure that your house has appropriate fly screens. As I said, if your partner has travelled to a Zika virus affected area, abstain from intercourse or use barrier contraception condoms for the duration of the pregnancy. There is a risk of local transmission of Zika virus. We want to make sure that pregnant women are protected. There will be testing guidelines available for health professionals. Our response to dengue may not be the best way to respond to Zika. This is because up to 4 out of 5 people with Zika have no symptoms. Currently, our response to dengue is one where we respond to notified cases. If 80% of people have no symptoms, we won't be able to respond to kill the mosquito within their house. In remote areas, such as the Torres Strait, environmental health workers working for councils will be providing an initial response. Please contact your local public health unit for further information, or if you suspect Zika, please fill out a notification form found on the PHM website.